Hey everybody, thanks for joining. We are going to, in a moment, get started with, I think, an interesting discussion that we are hoping to have with a medical professional who is on the front lines of the COVID-19 pandemic. She's a neurologist working here in New Jersey, and I'm hoping that okay, so she's just about joined us, so let's see. I can bring her into. There she is. Stand by, folks, for a second. Okay, here we go. Hey!
Hi!
How are you?
Yes. Hi.
Okay, so I was just explaining to our audience here on Instagram what it is that we're doing today. So I thought it would be interesting to talk to somebody on the front lines of the COVID-19 pandemic, somebody who is working along with others here, but just all around the country and trying to protect us, trying to save us. And so I'm really thrilled to be joined by Dr. Farah Fourcand, MD. And full disclosure, folks, Dr. Fourcand is my cousin. And so
yes.
I'm very proud to be able to have this discussion with you, but I'm also proud. First of all, let me just say that I'm just so proud of the work that you're doing. And I know that you're a neurologist, but like a lot of medical professionals, a lot of doctors across the country, hospitals across the country, especially in hard-hit areas like the one where we are right now, are asking for doctors to help out with the influx of patients that we've seen specifically in this part of the country, in the tri-state area. And so you are working at a hospital in Hackensack, right?
Yes. I work at Hackensack Meridian JFK Medical Center in Middlesex County, New Jersey, one of the sort of epicenters of the COVID crisis. Yeah.
So I'm just so happy to be able to talk to you and to share your insights with the folks who are joining us now. We've got a lot of people that are joining as we speak, so we'll just dive into it. First of all, I guess the first question, and I generally, when I do interviews like this, I oftentimes try to ask questions that I think that just regular folks would want to know the answers to. And so they're not always from a position of intellect, or they're not always from a position of, I know what's going on, because a lot of us don't know what's going on. A lot of us
don't know what's going on either.
Well, yeah, right, exactly, because the virus is so new.
Yeah.
And so I wonder, I guess the first question is, how are you and your colleagues doing? I mean, how are you managing the massive influx of people who have become infected in New York and New Jersey specifically?
So things have changed drastically. From what I see, I'm proud of my colleagues. We've stepped out of our comfort zones, stepped up to sort of things that we're not used to even doing. Our hospital has 499 beds. About 300 plus of those are COVID patients. So our whole hospital is COVID now. Floors that used to take care of, were PACU floors, now have COVID patients. We don't do elective cases anymore. Like, I'm a neurointerventional surgery fellow. We don't do elective surgeries anymore. The neurosurgery team that also works with us doesn't do elective neurosurgical procedures anymore. We've all just been redeployed to COVID. So for my group, we have critical care training as from a neuro perspective, because we're neurointensivists, neurointerventional surgeons, and neurosurgeons. So our hospital thought, well, if you can do neuro ICU, you can do pulmonary critical care, and you can take care of COVID patients. We take care of COVID patients that are very sick, the ones that are on the ventilator, have multi-system organ failure, are really, devastated. And it's been a very humbling experience, because so many of us are used to having a treatment plan and having outcomes that we expect. And this is things that happen here are so unexpected. And we try our best. We've been having to think a lot for ourselves, because although there's evidence out there, it's limited and it's experimental. We have to, and we have limited resources because there's so many patients and not every patient can get everything. Mm-hmm. So we have tried, we've used our, you know, common sense, our empathy, our, you know, our resources to just do the best that we can for these patients.
Farah, can you raise your camera just a little bit so you're getting cut off right around here? Just the other way. Yeah, there you go. Perfect.
There we go.
Awesome. So the people who you know, and my heart breaks for, one of the things that I think people have struggled with is when we first started to learn about this virus, and I know that we don't know a lot, but the initial reporting around it, even from myself and others, was that as far as we understood, it really, if you were somebody who had a pre-existing condition, what they call these comorbidities, or if you were much older, you know, elderly, that you were at great risk. And certainly thousands of people, not just here, but around the world, have recovered after having become infected with this. But the folks that you're talking about and the folks that you're dealing with, what are the chances of recovery for people who find themselves on a ventilator like you described, or who find themselves with multiple organ failures? Is there a way to bring them back?
There is. I mean, from our experiences, there is. And as far as that first point about patients who are older, who have pre-existing conditions, in our ICU, we have a whole spectrum of people. We have people who are in their 80s, who have multiple comorbidities, but we have patients who are in their 20s, 30s, a lot of patients in their 40s, a lot of patients who worked in the city and commuted from here to the city, who didn't have any pre-existing condition. We had one young man who lived in a house with his family, and I think one of his older family members got sick, and he got very, very sick. The likelihood of recovery, you know, we try to take what we see in different articles and different journals and the news with a grain of salt, and then we take it to our own experiences because things happen right before our eyes. When we all started, we got sort of a rundown, a breakdown from, you know, the people who redeployed us, the pulmonary critical care doctors. And it was that once they're on the ventilator, there is very little hope, and you just do what you can. You talk to the families because the families can't visit their family. The families cannot. We have to call them and update them and try to help them understand and for them to see through our eyes what's happening to their loved one. So we have actually extubated 5 very sick patients who were old and young, had multi-system organ failure, like infection in the blood, kidney failure, needing dialysis, and were able to successfully extubate them and not re-intubate them, meaning they made it through.
Define what those two terms mean for people who may not be familiar.
So when somebody has the coronavirus or COVID, and they come in with the respiratory symptoms of shortness of breath, and, you know, in the hospital, oftentimes a lot of patients do okay. They have oxygen masks on their face, they get sort of different sort of treatments, and then they're able to leave the hospital. And that's why you see, oh, we've had X, you know, number of patients be discharged from the hospital with COVID. But then there's a point where that doesn't work anymore, and patients cannot breathe on their own. And if that happens, a tube, it's called an endotracheal tube, is put down the throat and down the mouth into the throat and into the lungs. And then we have a ventilator, and the ventilator is a machine that artificially delivers breaths into the lungs for the patient because the patient can no longer breathe on his or her own. So when a patient gets to that stage, there's many different strategies we use. We have these funky ventilator settings that I was never familiar with before this. We sometimes prone patients, meaning we turn them over on their bellies to help them breathe better. We use we have our own sort of chemistry set of things that we try and use. But once a patient is intubated, meaning the tube is inside, being able to be extubated, meaning being able to show us by different things that we do, by challenging them to breathe on their own, is very, very rare. It's very rare to be able to take the tube out of a patient who needs to be intubated with COVID. So having that happen was ubiquitously increased morale throughout the ICU and throughout the hospital. And it really brought up the spirits of everybody. And it was wonderful, especially from doctors who, you know, before 2 weeks ago didn't even deal with this kind of stuff.
And that happened a couple of times. That wasn't just once.
No, we did it on last Friday for 5 patients consecutively. We had planned it like the whole week. We were like, you know what? We have these 20 patients. There were about 7 that we thought we can get them off the ventilator by Friday. And then we took baby steps, and, you know, we did this, tweaked this, did that. And then Friday and Thursday, we tested all of them. We sort of weaned them off the ventilator. We put down the oxygen level on the ventilator to see how much their own body can make its own oxygen. We just, and we put down the respiratory rate, or the rate of the ventilator, to see how much they breathe on their own without depending on the ventilator. Mm-hmm. And then Friday morning, I came in around like 6 a.m. or so. And I went around and I challenged those 7 people. 5 of those people, I was like, okay, we're going to do this. And then we go through this whole algorithm that we need to do to make sure it's safe for the patient, you know, that we're doing the right thing for the patient. We're not rushing something. And then our team felt comfortable doing it. And we went from room to room, with nurse to nurse, and respiratory therapist with respiratory therapist. And we extubated the first patient. Everybody was like, what's going on? Super curious. Like, this is an anomaly. What? Like, looking through the, you know, negative pressure. I'm like, no, that didn't happen. The second patient, everybody was like, whoa. The third patient was actually a gentleman that everybody had been rooting for. He was a younger guy who had a really sort of sweet story that had before coming in. And nobody thought he would do well because nobody had done well. And we extubated him and everybody was just ecstatic. And then the fourth guy and the fifth guy. And it was just like a little miracle, you know, and it was wonderful. So, I
mean, it's, you know, I think perhaps it's nice to think about the concept of a miracle, but really it is the science and the doctors like yourself and the nurses and the other medical professionals who are there, who are coming up with these innovative ways to treat patients that perhaps, well, that I know, I guess, didn't really exist because we don't know what this virus is ultimately. And I wonder, what does it feel like, I guess, when a patient who is teetering on the edge recovers because of something that you and your fellow medical professionals have done? What's that feeling like personally for you?
It's the best feeling in the world. It's the most gratifying thing in the world. Because in these kind of situations, there's almost no expectation. People generally we expect things not to go well, and that's the opposite of what we're used to. Usually patients, nurses, doctors, families expect a certain outcome. You know, you come in for a stroke procedure like a thrombectomy, which is what we usually do, like removing clots from people's brains when they have a stroke. People have a certain expectation of outcome. But in this case, because it's been so stressful and so unexpected, and really we're just trying ourselves to get through it. We're taking care of patients, but also as doctors and nurses, we're trying to, you know, physically and emotionally get through it ourselves. And it's taken a toll on a lot of doctors and nurses, physically and mentally. So just getting through it another day is what we're doing. It's day by day. So having somebody actually do well, get off the ventilator, and actually, the first guy, we extubated him, he did well. He actually looked over, made a half smile, and gave us a thumbs up. And it was wonderful. I had never felt like more, I don't think I've ever felt like more of a doctor. Wow. It was wonderful. And then yesterday I followed up to make sure everybody was okay. You know, nobody got reintubated and stuff. He was sitting the goal before taking him down was for him to sit in a chair, to be sitting in a chair comfortably before being able to leave the ICU. And for that, to think that people had not given up on him, but thought, you know, this guy is just going to end up, you know, passing away. And he was very close to passing away.
Wow.
It's wonderful. And to tell the families who can't be there, I don't even know what they're doing, how happy they are. Because I can only talk to them through the phone, and they try to have a level of composure. But when they come off that phone, I'm sure they were like, whoa, and cheering.
Of course. And we've seen videos, and we've seen, you know, we actually showed them on CBS this morning often, of people who survive and who come out of this, and, you know, they're being wheeled out of the hospital, and all the doctors and nurses and everybody is clapping, and
yeah.
You know, just that feeling of knowing that, you know, you've been able to save somebody's life. is got to be exhilarating. But it's contrasted with the awful numbers that we're seeing now. Where we're over 50,000 dead in this country, and I wonder, just for we talk a lot about the families and the people who are suffering through this without sometimes giving a lot of thought to the people who are on the front lines like yourself. And it's not just, we've talked about the essential workers because they're most at risk, but the doctors and the nurses like yourself who, for every success story that you probably have multiple incidences where you're not able to save somebody's life, and you're far away from home. I mean, you live in Florida, you're here in New Jersey. You're in a hotel room by yourself because once you leave the hospital, you're social distancing, and I'm guessing it's the same for all of your colleagues. So how do you just from there's that old joke, physician heal thyself. How do you stay mentally fit in dealing with the ups and the very exhilarating ups, but also the tragically depressive lows?
Well, honestly, it is hard to find time for myself. When I leave the hospital, I come to my quarantine hotel and I try to relax and prepare for the next day. So I have some degree of mental toughness at baseline, so I've been able to, I'm reasonably happy. I'm actually okay, but one thing that I think that we've done as a group, which is also a bit of work, but is empowering the frontline workers, is like a study that we're doing at our hospital. I'm the study director, and then Dr. Kamani is our the principal investigator. We're when this first started, we were concerned that some of the frontline workers didn't have appropriate PPE, didn't have appropriate sort of protocol for anything, and our hospital has done a great job at getting there. But in the beginning, it was all sort of unfamiliar territory for everyone. So we started a trial looking at hydroxychloroquine as a prophylaxis for frontline healthcare workers exposed to COVID. It's a safety study because there was lots of talk about the safety of hydroxychloroquine. It's an early efficacy study looking at whether or not the healthcare workers who initially were negative via the swab and the antibody testing are also negative at the end of the month. It's the same, the hydroxychloroquine dose is the same as the malaria prophylaxis. But this whole week, which I was supposed to be off, but I have been doing the clinical trial, is all these healthcare workers who are calling and being like, I want to be part of the study. I want to protect myself. I want to, I want something to come good out of this. I want to see if I have antibodies so I can donate plasma to patients. Like, it's been sort of a motivator. Even though they're working and they're doing all this, they want to be part of the study, want to be part of something that could potentially help other healthcare workers in the future, to prevent them from getting sick because we're very much exposed, and also to contribute maybe altruistically with plasma and different things to help. So for me, that's been like a something I've enjoyed doing over the past few weeks. We started writing the protocol probably like a month or 2 months ago. I don't know, like a while ago. But it's been great because I've met like so many doctors in the hospital and nurses and nurse practitioners and PAs and respiratory therapists. Our cleaning lady who's cleaning the ER, and who knows what she's exposed to. Like anybody who's a frontline worker, because it includes everyone. Right. From the doctor to the food service to transporters, everybody's a part of it. And I think it's really unified us. And I have to say, this is one thing, getting back to it. I have never been, all the hierarchies of medicine, the structure of among doctors, let's say like the chairman of our department, the program director, a fellow, and then the nurses and like all this hierarchy, unnecessarily so, that's really instilled in medicine, has started, at least in some parts, to disintegrate. And I love that we're all just people, and the human condition and understanding your fellow man, your patient, your doctor, your nurse, your community is way more important than what title is what and who's who. And that has been, I think, very unifying and empowering, and helped a lot of people get through it. Like, the nurse can cry on the shoulder of the chairman of the, it's really broken barriers in that regard. And it's been nice.
That's remarkable. And I know people are gonna they were just listening to you talking about hydroxychloroquine, and that's a medicine, a drug that we've heard a lot about in recent weeks. You mentioned it specifically in this one particular study that is happening at your hospital as a way, perhaps, to protect medical workers. There's been talk of using it as a way to help people recover from COVID-19, which I know is still being studied. And even though people have talked about it as something that can be conceived of for a lot of people as a cure, it is far from that. It's funny because I was familiar with that drug because when I was working at CNN, and I was the CNN West Africa correspondent before I moved to Nigeria, my doctor gave me, a whole prescription of hydroxychloroquine and the other drug, which is azithromycin. Yeah, thermycin, right? So I had this stuff. I probably still have some in my go bag, but that was for malaria. That was to protect me from malaria. And so there are studies I know underway to try to understand if it would work to help people recover from COVID-19. But this is even still different from what that is. This is a way to take it before you're exposed to COVID-19 to protect you from ever becoming infected.
Yes. So the hydroxychloroquine works to limit the replication of the virus. So in somebody who's exposed, like a frontline worker who is exposed, the hydroxychloroquine can prevent the virus from replicating and causing an infection, and reduces the ability for one to transmit the virus to somebody else who may be a little bit more compromised. In and of itself, it's limited. It's a medication that's been around for decades. And a lot of these medications we're using now are not new. They're old medications that have been, had a makeover and now being used for another purpose. They're not perfect. They're older. They have, potential adverse side effects and different sort of, issues. So that's why it's important that people are mindful of that, understand that take things in a controlled way, right? So the hydroxychloroquine we're using is the malaria dose, the malaria prophylaxis dose. And it's a safety study where we do an EKG in the beginning to make sure that there's not an abnormal rhythm that could be associated with the hydroxychloroquine. We look at different adverse effects over the 4 weeks. Of course, we want the medication to ultimately prevent the healthcare provider from getting COVID, but it's really a safety study. And these medications that we're using now, like hydroxychloroquine, like azithromycin, like some of the fancier stuff like remdesivir, the plasma, the antibodies in plasma, the tocilizumab, which is the interleukin-6 inhibitor, all these medications, like the tocilizumab was used for rheumatoid arthritis and juvenile arthritis, and remdesivir was used for the Ebola virus. They're older medications. And I think what is important to understand is they're all experimental with the coronavirus, with COVID. And what's really important is the supportive care that we've been doing in the ICU and getting people through, because a lot of these patients who were successfully extubated didn't get plasma, didn't get X, Y, and Z, but did well because we supported their body. We protected their kidneys. We made sure they didn't have too much fluid in their lungs. We made sure to prevent their blood from getting too thick and causing a stroke or causing a clot in their lungs. That's what we can do uniformly across the board. And it's not limited by resources. It's not limited by anything. It's something that a hospital can do for every patient. Wow. And those other treatments are great, but not every patient can get them. We have a plasma study actually that our neuroscience department is doing as well. And the plasma is a wonderful concept, right? Because after somebody gets the coronavirus, the virus itself causes the issues you have in the beginning. But once you get very sick, it's not the virus anymore. It's your immune system's response to the virus. That's what differentiates the person who does well and the person who gets very sick. So a lot of these medications that modulate or change the immune system or manipulate the immune system are what we're using. And there's many different approaches. There's steroids, there's IVIG, there's plasma exchanges. Like, you could just Google it. I'm sure there's like 50. And
but that raises a great question that I have, which is, I think all of us who have been working from home, the millions of people across this country who are social distancing and not being able to see their family, their friends, or go out to restaurants, are all worried about what would happen if they were to get it. You know, you hear those stories of people who are young and healthy and succumb to it, and then you hear somebody who, you know, fought in World War II survives it. And it makes me wonder, what you just said there about how the body responds to the attack that it's under is what will dictate whether or not you end up on a ventilator or whether or not you develop pneumonia. And is there, I don't know, so this is going to sound like maybe a completely asinine question, but you never know. Is it genetic? Is it, because what would, and this may be a very difficult question to answer, but you're my cousin, so I'll lean on the family connection here. What would make somebody who has no pre-existing condition, who is healthy by all accounts, succumb to this respiratory illness? And why would that be? I mean, I just struggle to understand why, somebody who can be very healthy can somehow things can go the wrong way. Like, yeah, is it genetic?
I think so. It's complicated, but
That's what I thought.
So first of all, as far as being a respiratory illness, what we're discovering now is that it's not there are some red herrings, right? That it's a respiratory illness. You have a pneumonia. You have this ARDS picture, which is an acronym for acute respiratory distress syndrome, but it's actually a systemic, whole body lack of oxygen. So there's lack of your red blood cells' ability to hold on to oxygen and deliver it to different parts of the body. The lungs are the most obvious place where that would first happen or show itself or manifest. But what we've seen as far as the multi-system organ failure, especially in the kidneys, is because there's not oxygen going around the body, and we've had ways that we've mitigated that. But I think what it is more than genetic, maybe epigenetic, like meaning your genetic makeup and then sort of the different environmental factors and different sort of over a lifetime that have affected your immune system. Because some immune systems are more susceptible to the virus than others. And because the really profound sickness that everybody worries about, because I think people are not that concerned maybe about a mild, flu-like symptoms, but when you hear people on the ventilator or unable to breathe or passing away, that's like a whole nother ball game. And I think that is more their unique immune system and the way that the virus affects that. So in a way that is genetic, but it's something more environment and genetics that you can't really see and you can't really predict, and which is the scary part, that you can't really predict it. That's why the 90-year-old guy may walk out of the hospital, and then the 22-year-old may not, and that is very scary. And for me too, as a young woman, I thought initially I was like, I'm okay, and then I'm like, I need to be careful.
Right,
it's gonna happen.
Yeah.
So, I think it's your own immune system, which has a genetic basis to it.
Do you worry? Because I know that in China and some other countries, in Italy, and even in the U.S., there have been a lot of medical professionals who've succumbed.
Oh yeah, we all worry. A few weeks ago, I had some mild shortness of breath, and I don't have any respiratory problems. I don't have asthma. I don't have anything. But I had some shortness of breath, and like 2 to 3 days before that, one of the COVID patients who was intubated, who was like in a comatose state, had like sort of gagged on his intubation tube. And I was leaning over right there at his ventilator settings, and I have a face shield, but it went right through, right here. And I was like, okay, all right. And then 2 to 3 days later, I felt shortness of breath, and I was worried. I was like, and I didn't, usually I try to be strong, not say a word, but I was like, this is not great, Brett. I need to tell my colleagues just in case. So I told my colleagues, and they were like, they worried. One of the nurses, Jacqueline, she's wonderful. She's like, got a pulse ox for me. She's like, Brett. I'm like, okay, I think I can. And then my hands were cold and it couldn't read, and everybody was freaking out. I'm like, I'm not toxic. I'm okay. And it went away after about 2 to 3 days. And then I got tested on Monday because I'm part of the study that I'm doing too. Right. And I was negative for the active infection. But I think honestly, I probably had it. I think there's no other way I could figure out, unless my N95 and all that stuff. I don't think so.
Wow.
I probably have antibodies, I'm assuming, which I hope I do, because our study also does antibody testing. So we'll see if we have antibodies. But a lot of us have had symptoms, and we do get scared. And a lot of the older doctors are especially scared. You know, a lot of the doctors in my hospital are like over 60, over 70. And there's, you know, a lot of them are the pulmonologists, the anesthesiologists, the ID doctors who are very much exposed. And they're very scared. And
Yeah.
it's, and, you know, you see the best and you see the worst out of everybody during these times. I'm happy that, and, you know, I've seen a lot of the good too.
That is, and I'm glad you pointed that out. I think, and it just, again, it's something that I think about every night before I go to sleep, and every morning when I wake up, which is not only for the families, not just in this country, but around the world, who are suffering because of this pandemic, but also the people that are at risk. And that includes, you know, like I said, you know, the essential workers, the people here in New York City who are, you know, delivering food and who are working as cashiers in pharmacies or grocery stores, you know, taxi drivers, but also like the doctors who, and the nurses. And as you pointed out, the people who serve food in the hospitals and who clean up, and all of those folks who know that this is dangerous and scary, but they have to go into work every day and they have to do their job. And and for that, I think all of us, all of the folks who are watching this, I know are grateful to you and to your colleagues for what you do. And I, you know, when you started medical school, did you think that something like this? I don't think a lot of doctors, I mean, even you can't imagine that the entire planet would be hit by a pandemic of which no one has seen for 100 years.
No, I did not think so. But, you know, I actually think this will change a lot of things. A lot of things. Obviously, there's a lot of bad, but I think it'll change a lot of things for the better. A lot. As far as healthcare, and, you know, especially how in the beginning there was just such chaos. We're like the most, quote unquote, you know, developed, evolved country, but there was such chaos and unpreparedness that a lot of the things that seemed almost like a cape over something, but underneath there was nothing to hold it down. There weren't any, there was so much lacking there.
Right.
That I think
on the surface, everything looked amazing.
Exactly.
Right. We pride ourselves on, you know, our medical technology, the education that our doctors like yourself go through to get to this level, the research that we do. But I think for a lot of Americans and a lot of people, this has exposed an issue that will hopefully be addressed by people in your profession, that will address that, you know, that there's you know, it's not enough to be the smartest. You have to have the resources to put those smarts to use.
Oh yeah, it's like you have the fanciest, biggest this and that, but when it comes to the basics, where are they? And that is what we really need. So I think it'll change things as far as physicians taking more, you know, leadership positions in the administrative side of medicine, because we think that way, we're geared that way. We would add to that, and I think that we need more of a voice in that regard too. Because a lot of times we're focused on just research, academics, patient care, that we forget that a lot of things are just multiple moving parts that we need to understand. Because the business of medicine shouldn't be such a business either. It should have the brain of somebody who's thinking of the patient.
Yeah.
And sees them and understands them.
Well, Dr. Farah Fourcand, thank you so much for spending some time with us today.
Thank you. Thank you.
It's so great. And again, for those of you who are just joining us or who just joined us in the last 15 or 20 minutes, Dr. Fourcand is here in the tri-state area working with COVID-19 patients. She's a neurologist by training. She's also my cousin, and we're very proud of her, but she's a neurologist by training. But so many doctors and nurses from across the country have been tapped to help combat this pandemic, especially in the hard-hit areas where we are here in the tri-state area. So thank you so much for what you do. And please take care of yourself, obviously, and you know, and be well and be safe.
Thank you. We're all trying our very best.
Thank you, Doctor. And hopefully, if you guys want to follow Farah, she's got a very interesting Instagram page. If you, I don't know if it's an open page though, but
Oh, it is, I think.
Okay,
yeah.
So like in your spare time, you're a model, you do all these other things,
Oh.
but you're amazing. You're like a Renaissance woman.
Well, Renaissance time.
Yeah, exactly. Thank you again for your service, Farah. We'll talk to you soon.
Thank you so much.
Thank you.
Much love.
All
Thank you.